Dr. Halkar is our next speaker. We're fortunate to have him on our faculty. He has been indispensable in our multidisciplinary treatment program, both at Grady and at Emory. Dr. Halkar is a director of nuclear radiology at Grady Memorial Hospital. He's a board-certified nuclear medicine physician, and Dr. Halkar has clinical expertise and experience in thyroid cancer and neuroendocrine tumor management. He earned his medical degree from the Government Medical College in Bellary, India, where he also completed an internship. He then completed his residency in nuclear medicine at Emory University Hospital and then his PET fellowship at Creighton University in Omaha, Nebraska. Dr. Halkar received the Marshall Brewster Award from the Southeastern Chapter of Society of Nuclear Medicine and Molecular Imaging in 2012 for his outstanding contributions to nuclear medicine. Today, he will be speaking to us about radioactive iodine ablation, when, why, and how much.
I am Raghuveer Halkar. These are my disclosures. When and how much radioactive iodine in differentiated thyroid cancer? Here in this slide, we have a histopathological slide of papillary thyroid cancer and follicular thyroid cancer, which represent differentiated thyroid cancer. This is a slide of medullary thyroid cancer, and this one is an anaplastic thyroid cancer. We will focus on our talk on differentiated thyroid cancer. What do we mean by differentiated thyroid cancer? Differentiated means how the cell looks under the microscope with H&E stain. A differentiated title does not inform us whether the thyroid cancer has iodide trapping function or organification function. This functional character of the thyroid cancer will be revealed by whole body iodine scan only. Differentiated word doesn't mean whether it is producing thyroglobulin or not. It doesn't give any information about proteomics or the genomic of the thyroid cancer. Now we have tests approved by FDA to test the genomics. Differentiated tumors are chemo and radio resistant. It's not only in the case of thyroid cancer, but also in the case of neuroendocrine tumors. This information comes from 1906 when Bergoni and Tribando formulated a law, and they said undifferentiated, that means highly mitotic and metabolically active and primitive tumors are more radiosensitive. So surgery is the first and the best option in most of the differentiated tumors. Then the question comes, why do we give radioactive iodine treatment for differentiated thyroid cancer? Anything can be killed if we give enough radiation. It doesn't matter whether it is differentiated or undifferentiated. If you can give enough radiation, you can kill it. So if external beam can give 60 grays, radioiodine can deliver 100 to 200 grays. Hence, that's why we use radioactive iodine for ablating the remnant thyroid tissue as well as treating differentiated cancer thyroid metastasis. And we rarely use external beam radiation for this purpose. Fortunately, vast majority of thyroid cancer is differentiated, and these are very indolent in behavior. Because of this indolent behavior, it's difficult to assess survival benefit, and very few long-term randomized prospective studies are available. And if you do a short-term follow-up, 2 different treatments or no treatment may not show any difference. With this in mind, in 2015, American Thyroid Association came up with guideline for managing thyroid cancer. It has 1,070 reference and had 75 recommendations some with weak evidences, and a lot of controversies. So in 2018, a matter of controversy was published in Journal of Nuclear Medicine regarding radioiodine therapy in differentiated thyroid cancer. And in 2019, American Thyroid Association, European Association Nuclear Medicine, and Society of Nuclear Medicine and Molecular Imaging and European Thyroid Association came up with a joint statement called as Martinek Principles. Martinek Principles addressed assessing the post-op patient and looked at remnant ablation, taking care of residual malignancy, and treating functioning distant metastasis. How often radioiodine is used in the management of differentiated cancer thyroid will depend on how does the cancer thyroid present. If vast majority of cases, like here in 1970 in India, were presented as large bone metastasis, then all of these patients would need radioactive iodine treatment after total thyroidectomy. Whereas in USA, since 2010, most common presentation of thyroid cancer is an incidental localization of a thyroid nodule, either by ultrasound or CT scan or PET scan. Here, the role of radioactive iodine is not as much as in cases of what we see here in 1970s. So, how does thyroid cancer is managed? The thyroid cancer initial diagnosis is often done by endocrinologists by an ultrasound-guided biopsy. And a fine needle aspiration, once it shows papillary structures and confirmation of thyroid cancer is made, patient undergoes total or near total thyroidectomy by surgeon. Then depending on the institution, patient may get a post-op whole body scan. And then subsequently, depending on the post-op whole body scan and the findings at surgery, patient may undergo sodium I-131 treatment by nuclear medicine or radiology department. And in some centers, routinely 7 to 10 day post-therapy scan is done, and some do not do this. But most of them will give thyroxine suppressive therapy, and it's given by the endocrinologist. And endocrinologists will quite often follow them up with regular thyroglobulin, and in cases whenever needed, ultrasound, and whenever needed, sodium I-131 whole body scan. Rarely, when the I-131 whole body scan is negative and the thyroglobulin is rising, but they may do FDG PET CT. This is a multidisciplinary approach, and at every level, there are controversies. So let us look at role of radionuclide imaging in evaluating thyroid nodule. A simple answer is the role is minimal. As you can see here, initially a TSH assessment is done. If the TSH is suppressed, then there is a role for I-123 uptake and scan. And if it turns out to be high, patient is managed accordingly. But if the TSH is normal or high, most of the management is with ultrasound and ultrasound-guided biopsy. Only if the biopsy shows indeterminate findings, then the role of I-123 scan comes into picture. Even this is less and less used because now there is genomic testing, and most of the indeterminate studies can be to a great extent told whether they are cancerous or not, or whether they have to come out or not. FDG PET scan is not recommended except in anaplastic cancers. What about staging? TNM staging does not change the sequence of management of thyroid cancer. What do I mean by that? Even if patient comes with a bone metastasis, the first step in the management is always thyroidectomy. Whether he comes with a very small tumor, the first step is lobectomy or thyroidectomy. and then only subsequent management starts. So staging usually gives prognostic information. It does not change the sequence of management. And the staging has been done with multiple different systems. There is an EORTC system and AGES and Sloan Kettering. The important point to know is age is an important criteria. Younger the age group, prognosis is better. The older the age group, prognosis is bad. Cell type and grading and histology adds a lot to prognostic information. And here are cells types that give bad prognosis, like tall cell, insular, hobnail, Hurtle. Again, these are morphological characterization. They do not tell anything about functional or genetic character of the tumor. There is a new entity called poorly differentiated thyroid cancer between well-differentiated to anaplastic. These are the in-between tumors, and the Turin proposal has defined when to call poorly differentiated thyroid cancer. Again, this also does not give us a functional character or a genetic character. Is there a need to ablate the residual thyroid tissue with sodium I-131? It depends on, has there been a spread already to a lymph node, or to bone or lung? If the answer is yes, then we need to ablate the residual thyroid tissue to get to the metastasis. If no spread, then what is the risk of metastasis? If the risk is very low, there is no need for I-131. However, ablating residual thyroid tissue makes follow-up easier with thyroglobulin. Of course, if the risk is high or there are bad players like tall cell or insular, then I-131 ablation of the residual thyroid tissue is needed. Thyroglobulin is a great tumor marker, but its precision is poor. And anti-thyroglobulin antibody presence will make the test results less useful. Of course, these days we have mass spectrometry and immunometric assays which can help in the presence of anti-TG antibody. TSH-stimulated thyroglobulin is more sensitive, and rise in thyroglobulin is less specific for recurrence of thyroid cancer when there is residual thyroid tissue. And this particular point pushes many patients to get residual thyroid ablation with radioactive iodine. How to do post-operative evaluation for residual thyroid tissue and metastasis? Do we need a post-operative whole body scan? And when is the best time? And what is the best way to do it? Not all thyroidectomies are same. Why do I say that? Lumpectomy and completion thyroidectomy versus elective total thyroidectomy may give a different result. And if there is difficult surgery, for example, if there has been an injury to the nerve or bleeding, can minimize tissues removed by the surgeon. So here are good examples. Here is a good total thyroidectomy. This is a 72-hour I-131 whole body scan. We see physiologic uptake in the stomach, bladder, and nasal mucosa and mouth uptake. There is nothing in the thyroid bed. No lymph node uptake. This is an excellent thyroidectomy with a 72-hour uptake of 0.04%. In contrast, here a patient who had problems with lobectomy and completion thyroidectomy was done, and right lobectomy was done in an outside facility and completion thyroidectomy was done at Emory, and we had more than 5% uptake in the neck, and you can see a star artifact here because of intense uptake in the thyroid bed. Another patient, a 60-year-old male patient, status post-total thyroidectomy, again 3.5% uptake in the thyroid bed. A patient with follicular cancer had a surgery, and we did a whole body scan post-operatively, and we see not only a lot of residual thyroid tissue, but we saw bone metastasis, and in fact one in the vertebra. So this pre-treatment evaluation before giving radioactive iodine helped us a lot. because we know that patient has a vertebral metastasis, I would get an MRI and make sure there is no cord compression, then only give radioactive iodine therapy. So post-operative and pre-ablative whole body scans make differences. So post-op evaluation with radionuclide study helps determine the management. The question is which isotope to use. I-131, the downside is stunning. I-123, cost and availability is higher. Technetium per technetate, poor sensitivity. But preferred method is still an I-123 with 2 to 3 millicurie of I-123. Here is a case wherein we have used a technetium scan. So patient had a difficult thyroidectomy, and we knew a priori that there was a lot of thyroid tissue left. So we opted for technetium scan, and there was whole lobes left. So in this case, we gave only 30 millicurie, because if you give 100 or 150 millicurie, patient would get a bad thyroiditis and have respiratory problem. Subsequently, after 3 months, patient got another technetium scan. It doesn't show much of residual thyroid tissue because 30 millicurie has ablated it. But then we went ahead and give 150 millicurie I-131, and the 7-day post-therapy scan shows considerable residual thyroid tissue. So this shows that 30 millicurie sometimes may show a negative technetium scan, but may not be totally ablating the thyroid tissue. Stunning, it's a controversial phenomenon. Some people believe and some people won't believe it. So stunning is seen if lots of thyroid tissue is left after surgery and there is more than a week delay between 4 millicurie and whole body scan and therapy. How to prevent stunning? Do good surgery, do an I-123 scan. If you do sodium I-131 whole body scan with 4 millicurie, treat without delay within 48 hours. And here is a case of stunning where the pre-treatment scan shows uptake in the skull, whereas the post-treatment scan did not show so much uptake in the skull. How good is I-131 to ablate the residual thyroid tissue when we give 100 millicurie? Here is a patient. This is a pre-therapy I-123 whole body scan, and you see residual thyroid tissue. This is a 7-day post-therapy scan after 100 millicurie. And after 1 year, the patient comes for a surveillance scan with I-131, and we don't see any uptake. So the residual thyroid tissue has been completely ablated by 100 millicurie I-131. Now the next question is when I-131 ablation therapy is not needed. Small tumors, no capsular lymphovascular invasion, then I-131 therapy for ablating is not needed. Of course, one has to make sure the histology does not have any bad features such as tall cell, Hürthle cell, hobnail, or insular, because these can run bad course. And in these patients, it's better to get rid of the residual thyroid tissue for further management. In patients who are younger in age, may not need I-131 ablation therapy, especially if the patient is small, if the patient tumor is small and no capsular lymphovascular invasion is seen. The only question comes is, if you have not ablated the residual thyroid tissue, how are you going to follow up? Because thyroglobulin now is not a very good tumor marker when there is residual thyroid tissue in the neck. So that's a question. How to give radioactive iodine? We usually do a consult. We do an assessment of the home situation. We take a written informed consent. In childbearing women, we do pregnancy test. We put them on low iodine diet, 7 days to 15 days. And we make sure that patient has not had CT with contrast for 4 weeks or 8 weeks. It can be done either with thyroxine withdrawal or thyrotrophin alpha stimulation. It can be done inpatient or outpatient, and we routinely do 7-day post-therapy scan. That's the Emory protocol, and usually we give 100 millicurie for ablating the residual thyroid tissue. When the residual neck uptake is more than 5%, then we fractionate the dose. We give 30 millicurie first, and after 3 months, we give 100 millicurie. By this way, we decrease the radiation thyroiditis effect. For lymph node metastasis, we give 150. For liver and lung mets, 200 millicurie. Recently, there are a few papers in New England Journal that propose 30 millicurie for remnant ablation. So how much to give? 30 millicurie for remnant ablation or 100 millicurie? So let me give you a long-term follow-up. Here is a study done by Mazaferi, which is a 40 years follow-up. And you can see there are total thyroidectomy and T4 thyroxine replacement group, subtotal thyroidectomy and thyroxine replacement group, subtotal thyroidectomy and radioactive iodine, subtotal thyroidectomy, total thyroidectomy and radioactive iodine group. If you look at 2 or 3 years or even 5 years, all the 4 have roughly the same prognosis. The recurrence rate is not significantly different. But if you look at 10 years afterwards, you will see the difference shows up, and total thyroidectomy and radioactive iodine and T4 suppression gives the best result. So what does this chart show us is that to make a decision between difference in therapies, you have to have at least 5 to 10 years of follow-up. These are the 5 or 6 papers that promoted 30 millicurie or less or 50 millicurie or less for ablating the thyroid tissue. Let us look at the follow-up in these studies. Most of them have 6 months or 6 to 12 month follow-up. And most of them used what is called as thyroglobulin or a subsequent scan, whole body scan, as the criteria for assessing the success of treatment. So this short follow-up does not mean anything in cancer thyroid, because these patients after 5 years may still have residual thyroid tissue may still show up, or they may develop metastatic disease. So this is little premature conclusion saying that 30 millicurie treatment is as good as 100 millicurie treatment. How much to give when there are lymph nodes positive at surgery or in the post-op whole body scan? 150 millicurie. And if there are bad features like tall cell in Surar Hartal, we may give 175 millicurie. And for bone metastasis and lung metastasis, we may give 200 millicurie. Many times more than one dose are needed in lung and bone metastasis, but if the cumulative dose is more than 500 millicurie, then we consider dosimetry. How good is radioactive iodine treatment for distant metastasis? Here is a case who had extensive metastasis in the lung, and we gave her the treatment with radioactive iodine with 200 millicurie. And then after 2 years, we did a whole body scan with I-123. There is hardly any uptake in the lung. And the question is, has the lung mets cured, or they have become non-radioactive iodine avid, or they have de-differentiated? So here is the CT scan. The lung mets have completely disappeared. Dosimetry. When we would do dosimetry, we want to give maximum radioactive iodine, but want to spare bone marrow and lungs. At EOH, we have used a criteria of less than 70 centigrade to the whole body. And to get this information, how to maximize dose without hurting the bone marrow and lungs, we need to do serial scans up to 48 hours or more. At least 3 data points are needed. So I-123 with 13-hour half-life is not a good tracer. I-131 becomes the ideal tracer. Now, an I-124, which is a positron emitting agent, that is available, but it needs PET-CT imaging. So most of the time we do with I-131, and thyroxine withdrawal is preferred over thyrotrophin alpha because thyrotrophin alpha has a short half-life and a pulsatile increase in TSH, whereas thyroxine withdrawal will give us a persistent increased TSH. Here is a slide showing how I-124 dosimetry is done with PET-CT and helps much better. How to manage surveillance of whole body scan negative and thyroglobulin more than 10. First time around, the guideline is to treat it with 150 millicurie of sodium I-131 and image 7 to 10 day post-therapy, and you may see the lesion. And the proof of the pudding is the thyroglobulin should go down in 6 months' time. Even after the above plan, if the thyroglobulin remains high, consider FDG PET or MRI or ultrasound to localize non-avid thyroid metastasis. So here is the FDG PET. Medicare does reimburse for differentiated cancer thyroid when sodium I-131 scan is negative and thyroglobulin is more than 10. And we prefer to do with thyrotropin stimulation. And here is a case where the whole body scan is negative. Patient has antibodies for thyroglobulin, 140, it's pretty high. Of course, thyroglobulin is normal because of the antibody. But then we did the PET scan, thyrogen stimulated PET scan. We see an intense uptake and we see a large lymph node. And this patient had surgery and then received radioactive iodine therapy. Another case of Hürthle cell cancer where thyroglobulin is more than 3000, but whole body iodine scan shows normal findings and no pathologic uptake. But then if you do an FDG PET, we see a large lytic lesion in the cervical vertebra with uptake, showing that this is a non-iodine avid Hürthle cell skeletal metastasis. This patient would need external beam radiation therapy to prevent cord compression. Emory is a tertiary care center. Majority of our cases are advanced or recurrent disease. So we often end up giving radioactive iodine therapy in most of our cases. And this is the protocol that we follow. Side effects are very minimal. Sialadenitis and dry mouth is the most common one. Occasionally you may see epiphora, and secondary malignancy is very, very, very rare. Summary, do post-op evaluation, and it is important to assess residual tissue and also to know lymph node status as well as distant metastasis. Low risk patient, young patient, negative scan may not need radioactive iodine, especially if the cell types are of good features. No bad features are seen in the cell type. However, ablating residual thyroid tissue makes the follow-up easier with thyroglobulin assessment. High risk patient, old age, bad features, large size tumor, lymph node involvement, lymphovascular or vascular invasion, radioactive iodine is needed. And we prefer 100 millicurie for ablation of residual thyroid tissue. And metastatic disease, if iodine avid, we give as we have discussed earlier. Dosimetry is done if extensive lung mets or bone mets are there and when the total dose has gone more than 500 millicurie. Special situation, if poor renal function, we decrease the dose by 50%. 1 dose of thyrogen is enough in ESRD. Patient on dialysis just before therapy and skip 1 dialysis and decrease the dose by 50%. Breastfeeding patient, lactating breast can get high dose of radiation from sodium I-131. So stop lactation for at least 4 weeks prior or use lactation suppressants. Stop breastfeeding for good after the treatment. So the last slide is when and what to use. As you can see, we have surgery, sodium I-131, external beam, and chemo and immunotherapy. For primary, surgery is the best option. For remnant removal, if there is substantial tissue left behind, surgery is still an option if surgeon is ready to remove it. Otherwise, remnant ablation is best done by radioactive iodine, and there is no role for external beam here unless there is a contraindication for radioactive iodine and there is skeletal muscle or tracheal uptake involvement. Palpable lymph nodes, if they can be surgically removed, surgery is the best option. Small lymph nodes with high thyroglobulin and good uptake, radioactive iodine is the best thing. Microscopic disease, radioactive iodine works very well. If there is a suspected cord compression or an impending fracture, take an orthoconsult or give external beam. Extensive iodine-avid metastasis, radioactive iodine is the best way. Extensive non-iodine-avid metastasis, go for chemo or immunotherapy. So as you can see here, when the disease, for remnant ablation, radioactive iodine is a good choice. For microscopic metastatic disease and extensive metastatic disease at two ends of the spectrum, when there is iodine-avid tumors, radioactive iodine is the ideal way to go. Thank you for your attention.